that was tremendous. It really was. And actually, I've got a suggestion, which is that it is more difficult to recruit some particular groups of people. And so researchers on the grants they have choose the easy route. I think that all the research councils that are involved in this kind of work and then IHR should be asked to make additional research funding available in order to recruit properly, accepting that these methods of recruitment take longer, are more time intensive and more resource intensive, and therefore should be properly resourced. And there should be a premium for research in this area. I suspect a premium for this kind of research would incentivize quite a lot of people. Am I just being a cynical old witch? Probably, but I suspect it might help. So we get to our very last session now, and it's a great time for anybody who's done their homework. You'll remember that yesterday we talked about online collaboration and consensus building in healthcare improvement. You were set some homework, and I'm now going to hand you over to Ruth Cousins and her team of Luke Steer, Jordan Moxey and Andy Patterson to find out what you thought, how you got on in your homework, and to tell us more. Over to you, Ruth.
Thank you so much. So welcome everyone to session 2 of the Thiscovery team's introduction to online collaboration and consensus building in healthcare improvement. Don't worry if you weren't at session 1, we'll be recapping at the start of today's session. I'm Ruth Cousins and I head up the Thiscovery team at this institute. And I'll be delivering, as Vivian said, today's session with my colleagues Luke Steer, Jordan Moxey and Andy Patterson. And Thiscovery is this institute's online research and development platform, which we'll be hearing much more about through the course of this session. So these are the aims for our 2 sessions. We want to explain why collaboration and consensus building is such a powerful tool for healthcare improvement, and explain a little about the modified methodology that the research team at this institute have developed to allow consensus building to take place online. And we want to use a real-life example to give you the opportunity to experience how this is delivered through the Thiscovery platform. And above all, we really want these 2 sessions to be the beginning of a conversation between us, building on the many brilliant conversations that we have daily with Thiscovery's community of researchers, NHS patients, staff and members of the public. So we built in opportunities for feedback and question and answer sessions both yesterday and today. Forgive me. So today I want to start by giving a brief recap on what was covered yesterday, and then my colleague Luke Steer will give you a little more detail on Thiscovery and how it works, using the demo task that some of you will hopefully have participated in either yesterday evening or this morning. And this task will be available for you to try until the end of today. So please do go to thiscovery.org/consensus to try it out. Then Jordan Moxey will share some of the results from that demo and put them in the context of the real-world research on primary care that she and her colleague Carol Sinnott conducted over the course of this year. And finally, we'll have an opportunity for questions to wrap up today's session. You can submit your questions in the questions box and we'll try and answer as many as possible. To briefly recap yesterday's session, we were joined by Clifford Coe from the American College of Surgeons, who gave us a keynote presentation describing his use of collaboration and consensus building techniques to support better decision-making around surgical interventions. If you missed the talk yesterday, it's available as a recording and I'd strongly recommend it to you. Cliff described a Delphi consensus building technique that he and his team used. In essence, the Delphi process brings together a group of experts, including healthcare providers, patients and carers, to enable them to reach agreement on a research question. This takes place over 2 or more stages. Firstly, where experts are asked to give their views on the question based on the available evidence and their own expertise. They're then brought together in a room to discuss further, and after this, they're asked to give their views again in light of the discussion. As Cliff demonstrated, this is a very useful methodology, but the requirement to bring people together face-to-face poses certain challenges. At the end of his talk, he asked us a question. Can we take advantage of technology and virtual capabilities to expand and diversify expertise and make collaboration and consensus building more feasible, efficient, effective, and less costly? After Cliff's presentation, Luke Steer described how researchers from this institute came to develop a modified Delphi consensus building process to respond rapidly to the challenges of the COVID-19 pandemic in an environment where face-to-face research was no longer possible. He discussed how the Delphi process was modified to take place online without the opportunity to bring experts together in the room, which is what is described in this infographic. The process is similar in that experts are asked to give their views, often by rating certain statements in the light of the best available evidence and their own knowledge and expertise. Rather than meeting the other panel members face-to-face, the information about how the panel responded in round one is fed back to participants, often as a graph of the spread of responses. They're then asked their opinion again in light of this further information. This online modified Delphi process has benefits over the original version in that it allows for much larger and more diverse groups of experts to participate more quickly and cost effectively, although from necessity it lacks the opportunity for face-to-face discussion. In all our work on Thiscovery, we're continuing to develop our approach to these methodologies, and an important part of this process for us is the opportunity to invite all of you in the audience to participate in these ongoing conversations. Many of you who took part in the demo task provided feedback, which Jordan will go over in more detail later. Luke discussed the different ways in which this technique has now been applied at this institute to tackle a range of tasks, including establishing best practice, developing frameworks, and evaluating remote care. There are outputs including frameworks, journal papers, and infographics available for many of these projects on the Institute's website. To close the session yesterday, we introduced the audience to Thiscovery and to the demo project that we set up for you all to help you get a sense of what participating in a Thiscovery project is like. There are some aspects that we couldn't replicate overnight, including the gap that occurs between phase 1 and phase 2 of a typical online consensus building project in order to allow for analysis and reporting back the panel's responses to round 1. But we hope that it was enough for you to get a taste. And I'm now going to hand you over to Luke to show you Thiscovery in a bit more detail.
Thanks, Ruth. So I'd better start by answering this question directly. So Thiscovery is an online platform, a website designed to help everyone get involved in research and consultation projects and generate stronger evidence for improvement. If you visit thiscovery.org directly, you'll be warmly welcomed. But in fact, most participants will reach Thiscovery via project landing pages, which are the hub of targeted multi-channel recruitment campaigns. So this landing page introduces the project with the information our audiences need to decide if they want to take part. If the project is relevant and of interest, existing users can sign in and take part straight away. But if it's your first time, you'll be asked to register. Here's the short registration form. We know that some people feel this step can be a barrier to participation, but for most studies, it really is vital. In the case of consensus building, we need to be able to invite you to subsequent rounds and also link responses. Following registration, you're asked to verify ownership of your email address by clicking a link in a confirmation email we'll send you. We found that some NHS trusts have overzealous, shall we say, email spam filters, which we need to resolve with each individual trust due to a diverse IT landscape. We're working on other ways for staff in particular to authenticate, such as facilitating single sign-on with an NHS.net identity. Once you've verified your email address and signed in, you're taken to a dashboard with your personal list of tasks. Those of you who signed into an existing account yesterday would have seen other active and completed tasks here. The dashboard is quite simple at the moment, really serving this single function. But as Thiscovery develops, this will be greatly extended and improved, we hope. Clicking through to the task page gives you some brief info about the project. But in a real research project, this page would include all of the participant information that's approved by ethics and required for informed consent. Our demonstration project didn't include this stage, but in a proper study, we would have then captured participants' consent. We record this at our end and also email participants a copy, including the details of what they consented to. Once they have consented, we can get on with the research task. The focus of this session has been on consensus building, but Thiscovery does support a range of other research activities. An important development has been our bespoke interviewing tool that incorporates functionality needed for research purposes, like automatic and secure recording and file transfer. We built further on this to offer asynchronous interviewing or on-demand interviewing, which allows participants to record responses to question prompts in their own time. Our development has been and continues to be led by the needs of research. Forthcoming developments include discrete choice experiments and photo upload and tagging. And we're hoping to have both of these up and running in early 2022. Researchers can acknowledge contribution in a variety of ways. Often participants are very happy just to be thanked. We know that from initial research that we did before building the platform. Sometimes we might acknowledge their participation in an authorship group on journal papers. For others, people are really pleased to receive certificates of participation that they can use to back up professional development records. Regardless, we'll always follow up with participants on the results of the projects that they have contributed to, closing the circle and emphasizing what their participation has achieved. So I'm now going to hand you over to Jordan Moxey, Thiscovery's program coordinator and researcher on the project that the demo task yesterday was based on, to recap on that and take you through some of the results.
Thanks, Luke. So for those of you who were here yesterday, we asked you to take part in a demo consensus building activity based on a real This Institute study called OFIG, which stands for Operational Failures in General Practice. So this study looks at a range of problems called operational failures that are known to regularly disrupt GPs at work. The term itself means problems in work system design or in the flow of work that impair workers' effectiveness. So not having what you need when you need it to complete a task, or being interrupted in the middle of doing something important. Some specific examples could include the computer crashing in the middle of prescribing a medication, electronic pop-ups which distract the GP, or missing letters from the hospital so the GP can't have an informed discussion with the patient sat in front of them. These sorts of problems make it harder for GPs to get work done, and we already know that GPs are very, very pressurised for time anyway. From our previous work in the OFIG study, we had found that there were 45 common types of operational failures that occur. And what we wanted to do is develop a short list of the most important ones to prioritise for improvement. So to do this, we used consensus building methods online on Thiscovery, the platform that Luke and Ruth have told you about. So this is where we asked you to get involved. We asked you guys to take part in a demo based on this study, where in round one, we showed you 3 statements of operational failures in pink boxes, and these are known to occur in general practice. And then we asked you to rate how important you thought it would be to fix or improve these problems on a scale of 1 to 9, where 1 is not important at all and 9 is extremely important. And then in the second part of the demo, we simulated round 2 of an online consensus building process. So normally there'd be a time lag in between round 1 and round 2, where we'd analyze results from the group and produce bespoke graphs showing the results of all those taking part. But because this is a demo and the time was only like a few hours, we actually showed you real research data from round 1 to inform the re-rating process. So we reminded you of the answer that you gave to round 1 at the top. Then underneath, we showed you the median average rating and the distribution of scores from real research participants. We then asked you, having seen others' results, how important do you now think it is to fix or improve the problem described? We then also asked if you'd like to provide any additional comments in the free text box below. So having done all this, how do we actually determine whether consensus has been achieved? So for this particular study, we wanted to create a shortlist of the highest scoring items only that had achieved our preset criteria for consensus. So that meant taking items with a median score of 7 and above, which meant they were deemed important. And we defined consensus in this study as having been achieved if 80% of responses fell within 1 score above or below the median value. It's really important just to say here that there's actually lots of ways of shortlisting and determining consensus, and it would be up to the researcher to decide how best to do it for their particular study. So let's look at some results. So I'll first show you some examples from OFIG, and then we'll look at what you guys rated in the demo exercise. So here's an example of an operational failure we asked OFIG patient participants to rate. So you've not been told the results of your hospital tests, so you see your GP to get the results instead. In round 1, which is the graph on the left, you can see that participants rated this problem as pretty important to prioritise for improvement with a median score of 8, but the level of consensus using our criteria in the top right box has not been achieved at that point. And then in round 2, which is the graph on the right, when we showed participants the round 1 results and asked them to re-rate, you can see that the level of consensus has increased a little bit, but it's still not achieved our threshold. Therefore, this item would not be selected for shortlisting. In a second example, this statement is your GP is unable to review your test result because it's missing. In round 1, you can similarly see that people deem this pretty important, but consensus had not been achieved as per our criteria of 80%. However, in round 2 on re-rating, you can actually see that consensus had been achieved by our criteria. So this is an example of a statement that would be included in the final shortlist. And I actually think this is a really interesting one. So when you put these two examples together, they're essentially saying that our patient participants thought it's important, but perhaps not critical if the hospital doesn't give them their test results. However, if they then go to their GP and those results are still not there, then that very much is an issue. And if you're interested in hearing more about the emerging results from this work, please go to this institute's webpage where you can sign up for updates. But anyway, let's move on to how all of you rated in the demo consensus activity. So the first statement, your GP finds that a piece of equipment or item they need is missing or broken. So in round 1, you can see that you all thought this was relatively important with a median score of 7, but there was a lower level of consensus around this particular issue with a consensus of 63%. And then when we asked you to re-rate after seeing everyone else's results, the median and consensus have increased a little bit, but they've still not reached our threshold. So this statement wouldn't be shortlisted by our criteria from the OFIG study. On the second statement, it was your GP has trouble booking a follow-up appointment with you at the desired interval because there's no available slots in the appointment system. So similar to the previous slide, in round 1 on the left, you have you've rated that this is quite important with a median score of 7, but a slightly lower consensus level of 68%. And then in the re-rating, so round 2, which is the graph on the right, you can see that both of those values have increased slightly, but still haven't kind of achieved our threshold for consensus that we had set. So the final statement, this was your GP is unable to contact other healthcare professionals by phone when they need them. In the first round, you all thought that this was pretty important with a median score of 8. And as you can see, you've already hit our level of consensus of 88%. And then in round 2, which is the graph on the right, that's just skewed even more to the right side. So we've got a very strong consensus here that this particular operational failure is very important to prioritize for improvement. So just to kind of look at all of those three together, if we were to take any conclusions from this, bearing in mind this is just a demo and it's not real research, you might say then that the only operational failure that would make the final shortlist for kind of targets for improvement would be the top one, GPs not being able to contact other healthcare professionals when they need. And that's because it was the only statement that achieved a median score of 7 or above and a consensus level above 80%. So finally, I just wanted to say also thank you so much to everyone who provided feedback on the demo and Thiscovery. As you can see with the examples on the slide, you overwhelmingly told us that the platform worked well, that you enjoyed it, that it was a positive experience. So we're really, really pleased to hear that. And we also had lots of interesting comments from you on why you did or didn't change your ratings. We also had one constructive point, and that was around the validity of the Delphi methodology, which is something that Clifford Coe talked about in some detail in our session yesterday. So I'd really, really recommend you having a watch of that if you haven't already. So with that, I think I'll hand back to my colleague Ruth, who will facilitate a Q&A and then share some closing thoughts. So thank you, everybody.
Thank you, Jordan. So yes, we've got some time for questions and answers now, and you can see the panel in front of you here. Joining Jordan, Luke and myself is Andy Patterson, who is the technical product lead for Thiscovery. So please do post your questions in the Q&A box, but we'll start off with some that we've got already. So perhaps Jordan, you might like to answer this one. How does Thiscovery provide for people who are digitally excluded?
Thanks, Ruth. That's a really, really good question and really important. I think we've had some very interesting conversations on this during this space over the last 2 days. So I can give you an example of what we did for the OFIG study, which is what I talked about. So we noted that so basically we wanted to sample patient participants from a wide geography, from different backgrounds, different ages, ethnicities, genders, condition groups. And we noted that, you know, not everyone is necessarily going to have access to a computer to be able to participate in this. So what we did was we partnered with 7 local health watch from across the country, and we worked with them to figure out how best could we potentially recruit participants who traditionally wouldn't use online methods. And what we had in a few cases is that the reps at each of those health watch groups would, let's say they had a potential participant to take part in the study, they would actually go with their computer or their device to that person's house, or that person would come to them, and then they would log into the platform on their behalf and then basically facilitate that person being able to take part. So that was, we had feedback from them and said that was really, really helpful. I know that there's also other ways that other studies at this institute have done to try and facilitate inclusion. And I think, Ruth, you may have some comments on, I think it was the COPD study that particularly used some other methods.
Yeah, so that study also offered a sort of paper-based format coupled with phone calls for people to participate in. I think it is fair to say that consensus building studies particularly are difficult to combine on and offline methods. It's particularly in terms of kind of rating the original statements, but we have made efforts to do that. I would say more widely on Thiscovery, most studies that have used Thiscovery in its various different modes of functionality have offered offline approaches as well as online approaches. And again, it's another kind of point of learning for us is how we can continue to combine those 2 methods in a way that's actually most effective both for participants and for research teams as well. So let's go on and have another question then. And I wondered, Luke, maybe you'd like to answer this one. How do you recruit people to Thiscovery projects?
Well, there's not, as you know, there's not one standard approach. It varies with the nature of the project and the profile of the sample, the individuals that researchers hope to engage. Also how many people we want to take part and what the research activity actually is. But we'll always start by designing our recruitment campaign off the back of an in-depth project kickoff, collaboratively between this institute's comms and engagement team, the project research team, and any partners, external partners that we might be working with on the project. Sometimes the call might be an open one. We'll go quite wide on social media, perhaps even promoting posts where budget allows. Paying to promote posts widens the audience, but it also allows us to target specific demographics if that's important. In other cases, we might need to take a more direct approach, and we'll leverage relationships with professional networks and membership organisations. Sometimes we'll ask participants to express interest in the project prior to inviting them to register on Thiscovery. That allows us to go out a little bit more open with our recruitment than we might want to be with sampling. So we do that so that researchers can have a finer control of their sample, for instance, to ensure that underserved groups are well represented.
Thanks, Luke. And I would just add, I think that one of the things we have found is most powerful in recruiting participants, even in an online setting, is really approaching them through trusted networks and working with organisations, whether they're, as Luke said, kind of professional organisations or voluntary organisations or community-based or faith-based organisations, to build trust with participants. And I think that applies offline just as much as it applies online. So I've had a question here about whether there is drop-off in participation between the different panels, and if so, how much, and how do we deal with it, factor it in? I don't know if Jordan might like to have a go at that one first, or somebody else if they want to jump in.
Yeah, sure. So yeah, the question about do we get drop-offs in participation, and I think it's somewhat expected in these types of studies that you may well get some drop off between rounds, and that might depend on how many rounds you do, what's the time interval between each round, so can you keep people engaged throughout the process, and then perhaps also the actual questions itself, so like maybe the number of statements to rate and whether that's too few or too many. So I think it definitely is a thing. Things that we've done to try and minimize drop off between sort of round 1 and round 2 is one, firstly, being really upfront with people about what they're signing up for. So it's like, this will be a 2-round survey and this will take approximately this amount of time over this time period, so that people know exactly what to expect. The other thing would be on Thiscovery, which is really great, is that you can send reminders. So if, let's say, you're in round 2 and there's maybe a group of people who haven't participated yet because people are busy and they forget these things, you can send like a nice friendly reminder at an appropriate time to say, hey, if you're still interested, the survey is open, we'd love to hear your response. And then there's other things that kind of Luke mentioned earlier about recognizing participation in these sorts of work, whether it is through either a simple thank you or whether it's through incentives like vouchers or certificates, or even the offer of like authorship groups as well. So I think there's lots of things that you can do to try and minimize drop off between rounds.
Thank you. And I think the very first online consensus building study we were really pleased by the kind of engagement that people had and the retention that we did have in between the rounds. And we hope and think that some of that has to do with relevance. So where people can feel that they really understand the problem that's being researched, they can really see how the process that we're going through enables kind of solutions to that problem, and things like Jordan's described with the issues that people have with GPs, that's very visible to patients, and it's something that people can engage with really easily. So I think that's a big part of being able to maintain participation between different rounds. So we're nearly out of time. There was one interesting question that's just popped up in the last minute or so. Was there anything that surprised you when you were developing Thiscovery as a platform? And Andy has been involved for the longest of all of us in developing Thiscovery as a platform. So I wonder if you've got any reflections on that, Andy.
Yeah, that's an interesting question. I think one of the things when I look back at when we started developing Thiscovery, one of the things that I had in mind was actually to expect surprises, to understand that we didn't know what was coming up, and therefore design the system accordingly. I think that's one of the key things, to make it flexible. I like, for instance, and responsive to the kind of changing needs that we're always going to have from research projects. Like Luke mentioned, the discrete choice experiments. This was never something that was thought about a few years ago. We were thinking about grouping and ordering things, and we explored that, and then that sort of faded away because the research requirement wasn't there. So like I say, it was always about trying to make that anticipate that we would have surprises, but we didn't know what they were yet, and try and design a system that could be flexible and accommodate those new requirements coming in.
I guess one surprise was that we started building it as a citizen science platform as well, wasn't it, Andy? Rather than,
indeed,
I mean, now
yes.
It's the way that this institute is doing research, or continues to do research. But
absolutely, well, certainly, I think also the effect of the pandemic was a surprise, and that the way that took it from a fairly low key part of what the organisation did to being really sort of front and centre of the research efforts. Yes.
So thank you very much to the panel, and thank you for everybody who asked questions. So just for me to kind of summarise in a sentence or two, I really hope that we've achieved the aims that we set out to at the beginning of this two sessions, and we've really enjoyed sharing our work with you. And we continue, as Andy said, to learn and improve and develop the platform, and we'd love for you to kind of continue that conversation with us. So that's the end of our session. Thank you very much.